Hi, good morning and good afternoon. I'm Gokul Kandaswamy, the consultants in the UK. I'm sorry I'm not there in person presenting this. However, I thank the organizers and the moderators for the opportunity. I'm going to talk about the role of robotic simple prostatectomy at this present day and age as one of the treatment modality for benign prostatic enlargement. Now, here classifies all the surgical options, which has gone leaps and bounds in the last decade into 5 different categories. The ideal treatment option, according to them, for volume of a gland below 80 grams is resection techniques, and glands above 80 grams is enucleation techniques. If you look at the enucleation techniques, pretty much all different forms of surgery that have a share of their role in such a technique, which is quite understandable because pathologically it is an adenoma that's developing, and large glands are more likely due to an adenoma rather than other sort of dysfunctions contributing to the symptoms. And when adenoma is the pathology, then enucleating is the is principally the right treatment choice. But do we have a consensus of what is the right treatment approach? The answer is no. Historically, open prostatectomy was thought to be the right choice, but even the resection technology has evolved and do have an enucleation option with the bipolar TURP. And the present so-called gold standard at the moment is considered to be the laser enucleation procedures. And EAU at the moment considers robotic prostatectomy as an investigational procedure. Why should it be the case? Because it is one of the youngest procedures described for such an indication. And it was only 14 years since the first paper came out. But if you look at all the parameters described in the paper, clearly is an exceptional result for a procedure that has been reported for the first time. But the number of papers on simple prostatectomy robotically is fairly low given the volume of cases that's across the world, and that's probably one of the reasons why it's considered investigational. Now, surgically, it is exactly similar to an open surgery, but the only difference is we are doing it with a robotic approach than cutting open someone's tummy. And in fact, the robotic approaches have even evolved using single port surgery, or even doing a intrafacial approach similar to a radical prostatectomy. Now, surgery is exactly similar to radical robotic prostatectomy in terms of positioning, anesthesia, etc. And once we reach the bladder, we either go transvesical or transcapsular. The transvesical approach seems to be the predominant type. Look at literature. And here, once your bladder is open, we straight away go to 6 o'clock position, securing the uvus and entering between the right plane once we open up the mucosa. If required, we remove the median lobe first. If not, once we enter the plane, we just go all around, keeping prostate capsule as the landmark so that we stay in the right plane all the time. The key thing to remember surgically is that adenoma sometimes extends beyond the urethral junction, and hence it needs to be entirely removed, and keeping this anatomical variation in mind. Once the hemostasis is done, then we reconstruct the bladder neck either circumferentially to narrow it down or to pull it down towards the prostate apex to retrigonize the part of the bladder. And finally, we leave a 3-way catheter in. And the intrafacial surgery is essentially a radical prostatectomy approach where we don't go between the adenoma and the peripheral zone. We basically just go outside the prostate capsule, but within the prostate fascia, thereby preserving all the neurovascular bundle which is outside the prostatic fascia, so that the erections and continence are maintained well. Advantages: we don't have to worry about 3-way catheter and irrigation. At the same time, the fear of missing a prostate cancer or following a prostate cancer in the future is also negated with this approach. And it has been reported 5 years ago as one of the modalities of choice. the robotic platforms have even evolved, and even the single port Da Vinci platform cases have been reported. And once again, if you look at all the numbers and the outcomes, they are very comparable to other surgical techniques. So clearly, even the novel surgical platforms do offer a treatment choice for these patients. So is it too complex to do on the console? Answer is no, especially if you're an experienced surgeon who's already doing robotic prostatectomy, which is what the bulk of the surgeries are done on this platform. Then you're only looking at about 10 to 12 cases as your learning curve cases. But what about your enucleation procedures, which is clearly not the case as compared to the robot, because this is a prospective study where out of 9 centers, three centers abandoned the idea of adopting laser enucleation. And even among those who completed their participation, only 4 continue to do this as a long-term basis. So the uptake is generally low, and this is after trying for 20 cases. So clearly the learning curve in general seem to be well above 20 cases. So do we have a consensus of what is the gold standard enucleation approach? Historically open. Nowadays, it's considered as enucleation with the laser. But is it time for robotics to be considered as a gold standard? Well, if you look at the literature between comparing open and robotic simple prostatectomy, we have about less than 1,000 patients in the recent systematic review, with operative time clearly in favor of an open simple prostatectomy. But if you look at all the other parameters, blood loss, catheter irrigation times, hospital stay, transfusion rates and complications, in all these areas, robotic approach is favorable. However, the only drawback in these studies I can come across is the volume of prostate gland before study seem to be fairly low, except for 1 or 2 studies where it is above 150 grams. And if you look at that study where prostate volume before surgery was roughly 240 on an average, again, operative time is the only place where the open approach is quicker, but definitely blood loss, hospital stay are better in the robot, and all the other parameters are quite comparable. So clearly, robotic simple prostatectomy is better than open. But how is it when you compare with laser enucleation procedures? Not many studies comparing head to head. In this systematic review this year, less than 1,000 patients. Again, so very similar outcomes. But again, the problem there is the size of the gland. Don't have much studies having large volume glands in their study group. And in fact, there is only 1 RCT so far where the study has been conducted on prostate volumes more than 120 cc. What does this show in general? Very similar outcomes like comparing to open, but the advantage with the robotic approach is it does offer the choice of removing more prostatic tissue, but no significant complications. But statistically, both these parameters are not significant, though. So does this mean one is better than the other? Well, this is a debate that's been addressed in European urology recently, and the argument seemed to be slightly going in favor of the robotic simple prostatectomy. Now, the only recognized disadvantage is the catheter time and the robotic approach, where it tends to stay for a week or so. But in laser enucleation, it comes out fairly soon. But it does cause urethral trauma, especially with the duration of procedure with large glands, and also very steep learning curve for the holmium enucleations. It also has a disadvantage that we can't treat other associated bladder conditions mentioned here. Now, the biggest issue usually is the operative time. Now, by the time you position patient, put ports, and then reach your prostate, it takes about half an hour robotically, but endoscopically you reach the gland straight away. But once the gland is very large, even if you reach the gland straight away with your laser enucleation, takes a very long time to dissect off the adenoma and then a long time to morcellate these large adenomas. And clearly that's where the robotic approach seems favorable, because this part of the procedure seems to be fairly standardized, and hence the overall operating time is always slightly longer, but never too long when it comes to very large glands. What's missing in the literature is this message of comparing the high volume glands, about volume of prostate more than 150 or 200 gram size. That's where the data is significantly lacking, and also about the storage symptoms and other long-term problems about readmission and intervention rates and so on. So where do we stand? I think robotic simple prostatectomy definitely has a role. It's probably well beyond the investigation, procedural investigation, as it's safe, comparable, and a feasible option. But I think this is particularly for prostate that is well beyond 150 grams or so. And it is quite an easy approach for people who are already doing robotic surgery. Learning curve is much better than laser enucleation surgery. Thanks for listening, and thanks for the opportunity.